Well, thanks, guys. Thanks for inviting me to talk to you guys about joint injections. So, what I'd like to review is why we do injections. We'll talk a little bit about the different things that we inject, the type of substances, and hopefully, I'll be able to answer questions that you guys might have about things before and after injection. Things that we have to think about when we do the injection is we have to kind of prep for the injection. We got to landmark very carefully. I think that's one of the most important things that makes a good injection pretty painless. And then we can talk a little bit about different areas that get injected. But depending on wherever you guys work, let me know what questions you have, and feel free to just raise your hand if you have something right on the spot. So one of the things that we inject a lot of is arthritis, just because our patients are getting pretty old and there's a lot of need for pain relief. So knees, shoulders, elbows, hands, ankles, everything can get arthritic. So that's probably the number one thing that we inject. But a lot of other things, kind of tendon problems, rarely muscle problems, but sometimes trigger points and some muscle problems we will inject. So those are other things that we do. When we talk about spines can inject discs in the neck, but theirs are a little more complex because they're going into the spinal canal, so they'll do those in the operating rooms. Whereas most of the other joints and muscles and things we can inject in the office. But a lot of times we'll use some imaging. And sometimes with the imaging, radiology is doing a lot of injections as well. So different people at UCSF can do our orthopedic type injections. So even pain service will do some, like with tendons and things like that. And just remember other groups do that.
The only thing I might add is also weight is a big issue too.
Yes.
And injections in office.
Oh yeah, for sure. That's a good point. Okay, so if you happen to work with the doctors and you're involved in any of the preparation, pretty much things that we need to do in an injection are the needles and the syringes, and there's different sizes of the syringes from small to 60 cc syringes. There's different needle sizes, so the bigger the number, usually the thinner the needle gauge is, so the smaller numbers, when you start getting 18, that's starting to get to be a pretty big fat needle. But doctors will have different preferences on that. They're gonna have different preferences of what they like to inject, whether it's the anesthetic or it's the actual steroid. We'll talk a little bit about that. But prep, one thing we always don't want is an infection after we do an injection. So the prep materials is gonna be important. But every doc has their own favorite thing. They'll use alcohol swabs, they'll use betadine, which is the iodine, but sometimes people are allergic to iodine, so there can be problems with that one. So, depending on your doc, they might have their own preferences, but as long as you anesthetize the skin, the risk of infection is 1 in 10,000. But that's probably the biggest concern that any doctor has after injection, is that someone's gonna get an infection, right? Especially the surgeons. Surgeons hate infection. So, sometimes the pain relief, some people will do an anesthetic injection where they're gonna put the needle in. Some people will just do the freezing spray, and that just numbs the skin. So when we talk about steroid injection, there's a lot of different steroids out there. We have Depomedrol, we have Kenalog, and we have Triamcinolone. Those are the three that we have on formulary. And they're like what we call moderate potency. Everyone always says, I want a cortisone shot, right? Everyone's heard of that word cortisone. That's what we used to inject in the 50s and 60s. No one really injects cortisone anymore. Like, you use it for your cream if you have a rash, but we don't really inject it in most cases now. We usually use one of those other things we talked about. When you look at it, it's like got a milky fluid in there. And it's got crystals inside. So the more thick and gritty it looks, that's less soluble. So if you think about solubility, things that are gritty and look like crystals are gonna hang around longer, but then they might have more side effects. So there's always positives and negatives. If something looks very milky and watery, it's probably very soluble. But that's good for soft tissues because it'll absorb into it. But then like when you want something to hang around in a joint, you don't want to get it absorbed so much. You might go for something with more crystal. Cool. So there's a bunch of different ways to get into the knee. When you think about the knee, it's just a big cavity. So you just got to get the needle into the knee. You can do it bent knee. You can do it with the leg extended. And I think you got to landmark and just know your anatomy. That's the most important thing to a painless injection. Because if you guys field phone calls about patients who have had injections, I'm sure most of them even say like, wow, is it going to hurt? That last one I had really, really hurt. It's because it's tricky. So let me show you how injections look. This is just a viscosupplementation. So what I'm doing here, I'm spraying the skin because I want to numb it so that the needle doesn't hurt so much. That only lasts for a few seconds, so a lot of it's psychological, but patients like it. They like that you're addressing their concern about pain. I just clean the skin with betadine, that already kills the bacteria. Then just holding the needle, I'm moving the kneecap around because I want to know where the joint is. And then I go quick through the skin. It's the skin that hurts, right? You don't want to be like really concerned and like messing up the skin. That's what hurts. And then I think one of the keys to watching a good injection is going slow. Don't go really fast. Imagine if someone took blood from you and then just went really, really fast and they didn't wear the right thing. That's gonna hurt, right? So if they go real slow once they get past the skin, as long as I don't hit bone, we're good, right? It's not gonna hurt. The only things that hurt are skin and the bone. But if you've had patients say, oh, that was really painful, it's because they hit the bone. So I inject the anesthetic, I had stuff in my syringe, and once I get it in the joint, it just goes right in and I anesthetize the joint. So now I know if I could, it hurts less, and I know, and then I can change the syringe, give them what they want. I can give them steroid, I can give them viscosupplementation as you're seeing here. And then it should go in very easily. It shouldn't be a struggle. Come out, that's it. Well done. And then you clean it up, and they walk out of there. And then they're anesthetized, and they're all happy, and then they leave. And that's the diagnostic part, because sometimes we do the injections to help the surgeons figure out if this is where they should fix. It's not only treatment. Sometimes we need to know, is it the knee, or is it the hip, or is it the spine? And so like we anesthetize the one area we're concerned about to see if that helped them, and then they need surgery for it. So this is just another example if you like these live things. This is me showing a resident how to do the injection from the inside. And so sometimes it gets stuck. They can't put the needle in. So a good technique is you don't want to just take it out all the way and just do it all over again. Then the patient has to go through the pain all over again. And they get 2 needle pricks. So sometimes I'll move the kneecap and just see if I can angle in. That's why it's so important to landmark. They should take their time. Unless they're the best surgeon on the planet can inject in like 1 minute or less, this probably should take a few minutes. You don't want people just going in there and shoving needles in. That's what hurts, right? So just that's kind of what you're gonna see when we do the injections. Questions or anything? Yeah.
So the first one you do is anesthesia, and then you can just switch in and put anything else in?
Yeah.
Doesn't matter.
Yeah.
That's pretty cool.
Yeah, and I use a 1 needle technique, but not all doctors do that.
Mhm.
Some people do a little skin bleb and they give you some anesthetic in the skin, so you get that needle, and then they go in with the other needle so that you don't feel the first one. But you already felt the first one, so why would you do the second one? I never got that logic. But if you're gonna be in the skin for a while, in all seriousness, sometimes if you do think it's gonna be a complicated injection, then you wanna numb the skin. Like sometimes when they're pulling out hardware and stuff like that, some of the doctors will do a block and block the whole nerve. If you're gonna do a lot of complicated things, you can do anesthesia different ways. Good question. Now, I think heavy patients, they're harder to feel the landmarks, not so easy. Plus there's more soft tissue. And these needles are only 1.5 inches. So sometimes you gotta go for the 3-inch spinal needle, the long ones. Then you can go in.
That's why sometimes you guys will see hip injections scheduled in the OR, because
Yeah.
sometimes patients, they tend to lie about their weight.
Yeah.
Until they're seen, and Dr. Zhang or Dr. O'Neill's like, you can't do it in office.
Yeah. So then, we often use fluoro, like on the hand side, there's a fluoroscopy machine. That's an X-ray that you can have in the room, and you can swivel it around and take quick pictures. But it is radiation, but they can see the needle and they can see the joint. That can help them get into wherever they need to be. They sometimes will do spine injections that way in the operating room. Then there's also ultrasound guidance. That's what I do a lot of. And we just use the ultrasound machine, same thing as the obstetric ultrasound machine. And we just look at the tendons or the joint, and I kind of guide the needle watching. We'll talk a little bit more about that in a moment. So what about after the injection? So I put anesthetic in. That's going to help people for around an hour. There's some longer acting anesthetics that last 4 to 6 hours. But after a while, it's going to wear off. So if you think about going to the dentist, you've all done it. It hurts for a little while, then the stuff wears off. Then afterwards, it's going to hurt. So a lot of times, depending on what we inject, they're going to be sore that evening. Now, if they have a little bit of tenderness, I always warn my patients, but what are you worried about? If people can't walk, they're way worse than when they came in. If they have a fever, they're feeling sick, they're not feeling right, then you got to worry about an infection. But just swelling a little bit isn't usually an infection. You got to be worried about it. When in doubt, always think infection. But most of the time, if it's 1 in 10,000, the fact that he's going to be that unlucky person, that's, unlikely. Most of what we worry about is just, local pain from the injection. The needle kind of hurt, it bled a little bit. Those are the kind of things that bother people. Now the steroid's going to kick in around 48 hours. So 2 to 3 days later, if they had a steroid injection, that's when they're going to start feeling relief. In terms of what we tell them afterwards, we usually tell them to take it easy for around a week. This is after steroid injections. There's not a huge amount of evidence, but somewhere around a week after injection is probably a good time for people to lay off. Because you even want the steroid to start working, right? If people start running around and abusing their knee after you inject it, it's probably not going to be so good for them. Questions? All right. So there's other stuff that we could inject. There's viscosupplementation, and that's hyaluronic acid. This is another thing that we do for arthritis. It's only approved in the knee, but we do it in other joints, like the shoulder, the hip, and we sometimes try to get authorization for that. It's made out of rooster comb cells or sometimes bacteria. And so the idea of this is your knee has lubricating fluid inside, but when you have arthritis, it's not so lubricating. It sometimes gets very watery. It gets beat up by the joint. So by injecting the stuff back into the joint, it stimulates your knee to produce healthier, thicker fluid. So then it lubricates. So a lot of people think you're oiling up the joint. You're not really oiling up the joint. You're just stimulating the knee to produce healthier fluid. So there's a few different products. We have Synvisc, Uflexa, and Orthovisc on formulary here. The reason why I put the horse picture is this was first done in racehorses. And if you know how valuable racehorses are, they needed to keep them running, so arthritis would be a bad thing for their racehorses. And they figured that it worked for them, so then it's probably good for people too. So. All right, there's different types of viscosupplementation. They're based off the weight. If you look at all the ones down here, they're all fairly low weight, in which case they're very soluble. But the last one, that Synvisc one, is very big. And that's why it's kind of the most similar to normal joint fluid. So this hangs around in the joint longer, and that's where it can cause some problems. So if you guys have ever had to do authorization for these things, they've gotten a lot harder over the last couple of years. And that's because some of the doctors out there they're not convinced with the evidence anymore. They don't think the amount of improvement from these injections is worth the cost. So it's only like an 8% difference from this stuff. It's not to say it doesn't work, they just don't feel that 8% is enough. Hard to say what the justification is on, is that function, it's good enough, like 8% doesn't sound like a big number to me. But the thing is, like, when you get 0% if you do nothing plus 8%, that's not bad when you're like, the alternative is 0. But be it as it may, that's what's going on. Now, what people have learned is that viscosupplementation lasts longer than steroids, so that's why it's an alternative. You've probably heard you can't inject steroids too often, and so this is an alternative to steroid injections for arthritis. Most people only get 3% local swelling side effects, so that's not that big. It's not a big deal. The local side effects usually have a little bit of swelling, but there's, infection and purity of the stuff is not usually a problem. You can't do it if someone does have a skin infection or a joint infection. If they're allergic to eggs, you can't have Synvis. The other ones are okay. And if you have a big fat swollen knee, you gotta rule out other problems. You can't just say that's arthritis. You don't always inject, and it's not gonna work so well in severe arthritis. So who you wanna use these viscosupplementation things are people with mild arthritis, and you can't do it for just cartilage, like a meniscus problem. This stuff's not gonna work for that. And if they're not doing well from oral medications and stuff like that. It's not gonna last forever though. Questions or anything, or does anyone use these in their practice?
Yeah, Dr. Beanie and Dr. Ward use the
Yeah.
Synvis.
Okay, cool. And so, I think it's a good option. It's not gonna save the world, it's not gonna grow back cartilage on something, but if it makes them comfortable, they don't have to take as much NSAIDs, they're more active, I think it's a good thing. All right, so what about shoulder injections? We inject things like rotator cuff problems, we inject arthritis, and then we inject frozen shoulders when they're too stiff. We sometimes do a steroid injection to help them out. So this is what the shoulder injection looks like. I like to do them from the back, and I'm landmarking pretty carefully. I'm feeling the soft spot in the back of the shoulder. And if you watch the shoulder surgeons work, they actually put their scopes in that little soft spot that you feel in the back of the shoulder. That's the best way to get it. So I used to draw these lines, but now I feel pretty comfortable just feeling everything. But for all intents and purposes, that's the shoulder blade that I just drew out. I'm drawing the front of the shoulder called the coracoid. If you feel in the front of your shoulder, you'll feel a bump right in the front. And that's where some of the muscles and tendons attach. So then I feel the soft spot. And again, I think landmarking is super important. You want to feel the joint and know where you're going. So I freeze the skin. And I'm cleaning it within a betadine. Oh, there we go. Okay. Now I kind of feel the spot, and then I take my needle, I find the spot I want to go for, roll my thumb out of the way a little bit, and then do my injection. I go nice and slow. You should be able to pass it all along the subacromial space, and then when you inject, that's going to spill all over the rotator cuff, which is right throughout the shoulder. So that's what people usually do for a rotator cuff type tear. All right. Cool. So questions? I just want to see if you have any questions before I go on to just explain about the final things that we inject. No? Okay, so we can inject local anesthetic. So lidocaine, xylocaine, bupivacaine, bupivacaine. They again all last a little bit differently in terms of duration. But other than if you're injecting into joints a lot, the local anesthetic's not the most important thing. So we talked about steroid injections. Prolotherapy, anyone know what that is?
I've heard of that.
Yeah, that's like injecting high dextrose sugar water into or right near a tendon, and that induces some response. So for steroids, we talked about that. When you do prolotherapy, the sugar kind of causes the tendons to inflame. So a lot of times we want it to heal. So that's why people do sugar, because it's kind of irritating to the body, and the body will try to get rid of it by getting inflammation. Now, the most popular thing is platelet-rich plasma injections now. Okay, now, have you guys heard about that one? So this is actually taking your blood and then spinning it down so you just get a purified platelet layer with some serum. So as you may know, platelets stop your body from bleeding. And when they plug up the hole, they release mediators that tells the body they should fix this area. So that's how it works. So by concentrating them from your blood and injecting them into an injured area in your body, you might get higher healing response because all those cells are already there. You just injected them there. That's why that's supposed to work. There's probably some anti-inflammatory effect as well. So that's a really popular one. Has anyone heard of Kobe Bryant going to Germany to get knee injections? Mm-hmm. Yeah, you've heard about that, right? That was probably like 6 years ago. You still remember that. It's like, that's why all your patients know about PRP, because the pro athletes are doing it and it's very popular right now. The private clinics are doing this a lot, and we don't know how much to put in, how long you should rest, all those kind of things. We don't really know. Does it work? It does seem to work for some tendon problems like tennis elbow and and some muscle pulls and things like that. For arthritis, they're even suggesting that it can work. So it's becoming very, very popular. I don't know if you guys have docs that do it. Anybody?
No.
Well, I'm doing it. Dr. Chang's doing a little bit. Dr. Lansdowne's been trained on it. Dr. O'Neill and those guys are doing a bit of it. Yeah.
I haven't scheduled it here.
Yeah. But, you know, it's popular and patients are going to ask for it. Sometimes it's hard to do these injections, and, you know, having ultrasound to visualize is very helpful. Whether it's like the shoulder, the hip's pretty deep to pass the long needle in there. There's also soft tissue problems like bursitis or plantar fasciitis. Those kind of things are things you can look under ultrasound and make sure your needle's going the right place. Then, you know, in the operating rooms, we often do fluoroscopy for hip flexor tendons, SI joint, or spine injections. Questions? Cool. These are just examples of different ultrasound-guided problems. This is some with calcium that's stuck in the supraspinatus tendon. So that's a pretty big chunk. Like that's probably, those little hashes are 0.5 centimeters. So it's probably at least a 1.5 centimeters or 2 centimeters. And then sometimes they'll stick needles in and try to break it up and suck the stuff out. I've been having a lot of problems trying to do that. I don't think it works so easily, but that's what some people will do.
Would that have to be done in like the OR to do it?
No, we do them in the office, yeah. I'll do calcific tendinosis injections in the office. And then, but the problem is you suck the hole out, the stuff out, now you got a big hole in the tendon. That's not so good. Biceps responds well to a steroid injection. So this is kind of like a side view of the, sort of a cross-section view of the shoulder, and then you're just gliding right over with the needle and then inserting into the sheath. You kind of see that bright line over there on the right, and that's going into the tendon sheath. It's just other questions, but you can get pretty precise doing a needle. It's a lot more accurate than doing it blind. All right, that was just another knee injection. This is fluoroscopic guidance. They'll inject dye into the hip, or just use the machine. You can see the outlines of the bones very well. So sometimes they'll do the spine injections and stuff with it. So yeah, those are the kind of the questions, hopefully you find that injections are useful for your patients. You just have to sometimes pick the right patient as well as pick the right solution that you can inject. But they're pretty commonplace and we do a lot of them upstairs. So, thank you for always helping and Merry Christmas to all of you.
Thank you.
Any questions or anything?
How often, so say you give a patient a new injection, how long you said does it last? Does it depend on the
A steroid
patient,
injection for mild arthritis lasts 6 to 12 weeks. If you're using hyaluronic acid, it's gonna be 6 to 8 months.
So do they come in like regularly after that, or is it kind of like?
They will, like if they found that it worked,
Mhm.
they're gonna come back. Now, steroid injections, I don't like doing more than 2 to 3 per year in somebody who doesn't have any other options. Usually the way I practice, you do 2 to 3 injections at the most. If you're not getting better, then probably need something else done.
And some insurances won't pay for it anyway if they're done very closely. That's why they space them out, like almost 2 to 3 months out.
Good question.
Will only cover like 3 to 4 a year.
Who will?
Medicare.
Only 3 to 4 a year.
Yeah, Medicare's pretty decent. There are insurances paying for PRP now. Blue Cross does. But you can see that sometimes they're removing other things. It's an option there. All right.
Thank
Thank
you.
you.
Thank
so
you
much.
guys. Happy
Thank you.
holidays,
Happy
guys.
holidays.